I'd like to thank the imprint organizers as well as Elenika Fletcher for inviting me to give this presentation on overcoming current challenges in assessing fetal drug exposure through PBPK modeling. I'm Jash Unadkat, professor in the Department of Pharmaceutics in the School of Pharmacy at the University of Washington in Seattle. Let me begin by stating the problem that we face. The problem that we face is that pregnant people and their fetuses are therapeutic orphans. And what do I mean by this? About 82% of pregnant people ingest one or more, let me get my pointer here going. About 82% of pregnant people ingest one or more drugs off-label during pregnancy because of pre-existing conditions like autoimmune disorders and those caused by pregnancy, example, preeclampsia. And this is the case despite that most of these drugs have not been tested in pregnant people for their fetal and maternal safety, efficacy, or pharmacokinetics. So what are the challenges in determining fetal safety of drugs? And here I'm going to focus primarily on fetal safety of drugs in the interest of time, rather than maternal efficacy and maternal safety, which is really a subject of a larger conversation. And we've done work in those areas as well in terms of determining and predicting maternal pharmacokinetics of drugs. So the challenges in determining fetal safety is that it's often difficult to determine this parameter due to logistical and ethical reasons, especially prior to approval by regulatory agencies. Because randomized controlled trials are often not possible or even ethical, even after approval of the drug for the non-pregnant individual. So what are the alternatives that people have used in determining fetal safety of drugs? So people often do prospective or retrospective observational studies once the drug has been approved and is starting to be prescribed and being, prescribed to pregnant people. And so there's retrospective and prospective observational studies to see whether there is any issues about fetal safety. The problem with this approach is that often fraught with confounding factors because it's not a randomized controlled trial. What about animal and in vitro studies? Can they predict fetal safety? Well, sometimes they can, but they're often conducted at doses and concentrations that do not reflect human fetal drug exposure. So it's a bit of a catch-22 situation. If you don't know what the human fetal drug exposure is, then how can you do the appropriate animal and in vitro studies using pharmacologically relevant concentrations of these drugs? So the only other alternative is that can we measure human fetal drug exposure, or for that matter, predict it throughout pregnancy to inform appropriate animal and in vitro studies? And fetal drug exposure is important to determine because that's what drives fetal safety. And so it can inform fetal safety of drugs. Now, what determines fetal drug exposure? Well, maternal exposure, which is driven by maternal clearance, is the single most important element and factor in determining fetal drug exposure. But there are other elements as well. For example, the drug may be transported across the placenta, or it may passively diffuse across the placenta. But the placenta is richly endowed with transporters, so placental transporter is often also a significant determinant of fetal exposure. There could be metabolism of the drug in the placenta, but it's often insignificant because major drug metabolizing enzymes such as cytochrome P450 enzymes are not highly expressed in the placenta. And then finally, one other factor that determines fetal exposure, fetal drug exposure, is fetal drug clearance. And this is primarily hepatic clearance by the fetus, and primarily by cytochrome P53A7, which is the predominant enzyme, cytochrome P50 enzyme present in the fetal liver. So how can we determine fetal drug exposure? Well, often a single umbilical vein, plasma, and maternal plasma drug concentration determined simultaneously, and the ratio of this, the UV-MP ratio, at term is often incorrectly interpreted as a measure of fetal drug exposure. And the reason why I say it's incorrectly interpreted, because it could vary with time and does vary with time and could be practically zero. For example, if I give a drug as an IV bolus to the pregnant person and measure the maternal plasma concentration at close to time zero right after administration, and in the umbilical cord, in the umbilical venous plasma, then the concentration in the umbilical venous plasma will be practically zero, and therefore the UV to MP ratio will be practically zero. Or it could be 1 sometime in this time profile, or it could be almost infinity when the plasma concentrations are significant in the cord plasma, but very little or undetectable in the maternal plasma. So what is the best measure of fetal drug exposure? The best measure is to do the area under the curve of the umbilical venous cord plasma concentrations, or the average steady state concentration. And sometimes, of course, the maximum concentration is also a determinant of fetal safety, and therefore the maximum steady concentration would be nice to know. But ideally, what we'd like to know is the corresponding unbound values of these parameters, as it is the unbound drug that is pharmacologically active. So what is the solution to this dilemma? The solution is to collect multiple umbilical venous maternal plasma samples, meaning from multiple maternal fetal dyads at term, and pool the data and pretend they came from one individual to get the full profile of the area under the curve in the UV to maternal plasma ratio and the Cmax, which is the maximum ratio of the UV to MP plasma. And of course, the corresponding unbound concentration. And this corresponding unbound concentration of the AUC and the steady state average concentration is called KPUU. And I'll be speaking about this in a few moments. So this approach also has a limitation because it's possible only at term and often not available for most of the drugs consumed by the pregnant person. And of course, this approach can only be applied at term and cannot be applied at earlier gestational ages because we cannot actually sample umbilical venous plasma at earlier gestational ages. So before I go to talk about KPUU, what is the solution to this dilemma that we face of determining fetal drug exposure? And the only approach that we know of is to be able to predict the fetal drug exposure throughout pregnancy. So let me explain to you what KPUU is and how does it differ in the absence and presence of transporters. So again, I just want to reiterate that KPU is the unbound fetal drug exposure relative to the unbound maternal drug exposure at steady state. So it could be the AUC, the unbound AUC ratio, or the steady state unbound average concentration ratio in the umbilical venous plasma versus the maternal plasma. Now, for drugs that passively diffuse across the placenta, then KPU is basically 1. And therefore, for these drugs, once we have the maternal plasma steady state concentration, then we can predict the fetal unbound steady state concentration. So this is basically a no-brainer. However, in order to predict the maximum unbound steady state concentration, we'd have to do some PBPK modeling, which I will speak about. So the bigger problem occurs when KPUU is less than 1. And this is true when a drug is actively effluxed by the placenta. And the placenta is richly endowed with efflux transporters, such as BCRP and PGP. These are expressed in the syncytial trophoblast, on the maternal-facing membrane of the syncytial trophoblast. And syncytial trophoblast is a multinucleated cell layer that basically separates maternal blood from the fetal blood. Now, of course, there could be that KPU is greater than 1, although I don't know of any example of such an occurrence, because the placenta is also richly endowed with influx transporters that bring in drugs from the maternal compartment into the placenta and therefore into the fetal compartment. And of course, the efflux transporters are effluxing drugs from the placenta and therefore from the fetal compartment, and therefore resulting in a KPU of less than 1. So because we cannot sample earlier in gestation to determine KPUU of a drug, to determine fetal exposure to the drug, can we predict this exposure through in vitro studies and maternal phenotyping studies and modeling? And the answer is yes. We can use PBPK modeling plus these additional in vitro and maternal phenotyping studies to predict fetal drug exposure. And I hope to convince you of this by the next series of slides. So let me just remind you that fetal drug exposure is driven by maternal exposure. And we can determine this maternal exposure by phenotyping studies. And I won't go into how we do this because in interest of time, but we've published a number of papers on this aspect. So please look those up in your databases. So I'm going to now focus on placental transporters and fetal drug clearance and how those can be determined by in vitro studies together with the phenotyping studies to predict fetal drug clearance through modeling. So once these studies have been conducted, we can populate our maternal fetal PBPK model with these studies, as well as data, physiological data, on gestational dependent changes that occur during pregnancy and throughout during pregnancy, including the first, second, and the third trimester, such as cardiac output, tissue blood flows, changes in hepatic and renal activity and expression of enzymes and transporters, and so forth. So what is a PBPK model? PBPK model is none other than a compartmental model that basically divides the body into different compartments, major compartments in the body, in the maternal compartment, as well as in the fetal compartment. And the fetal compartment, you can see, is divided into various aspects of placental clearance: passive diffusion clearance and active influx from the fetal compartment to the placenta, or active efflux from the placenta into the fetal compartment, and so forth for the maternal compartment as well, placental maternal transport as well. So we've utilized this model to ask the question whether our model works or not. First for passively diffusing drugs, and then I will speak to you about those that are actively effluxed by the placenta. So theophylline and zidovudine, or AZT, are drugs that passively diffuse across the placenta. So there is bidirectional passive diffusion, and this passive diffusion is equal in both directions, from the placenta to the fetus, and also from the placenta to the maternal compartment. And as you can see here, that our maternal fetal PBPK model is able to predict the theophylline maternal plasma concentration, as well as the fetal umbilical venous plasma concentrations very well, in fact, within the confidence intervals of the observed data and the predicted data. Likewise, for AZT or zidovudine, we're able to predict the maternal concentrations really well. And likewise, the fetal plasma concentrations, umbilical venous plasma concentrations really well. Now, what about drugs that are effluxed by the placenta? So we chose 5 PGP substrates and 2 PGP and BCRP dual substrates, because these transporters are the ones that are highly expressed in the human placenta. And then we conducted in vitro studies to determine the transport of these compounds in cell lines that highly expressed either PGP or BCRP. And we determined something called the efflux ratio. So for example, for a PGP substrate like darunavir, we determined the efflux ratio in the absence of the PGP inhibitor like toriquidar, and the presence of the PGP inhibitor toriquidar to completely inhibit the PGP transport. So the difference between these two efflux ratios gives us the PGP-mediated efflux ratio. Now, what is this efflux ratio? Efflux ratio is really the permeability from the basal to the apical compartment of this cell line divided by the permeability of the drug from the apical to the basal compartment. And as you can see, this cell line in a transport apparatus basically, in a sense, replicates the syncytial trophoblast of the placenta, which is where PGP and BCRP are highly expressed on the maternal-facing membrane of this multinucleated cell layer. So having obtained the PGP-mediated efflux ratio, what we do is that this ratio is determined by the abundance of the transporter in the cell line. And of course, these are overexpressing cell lines, and therefore the abundance of the transporter, for example, PGP, is much greater than that in the placenta. And therefore, we need to correct for this difference in abundance. So that's what we do by something called the relative expression factor. What is the relative expression factor? It's really the PGP abundance in vivo in the placenta, which we have determined, not only in the term placenta, but the first trimester and the second trimester placenta as well, divided by the PGP abundance in vitro in this cell line that overexpresses PGP. And we do this by quantitative proteomics. Having obtained this relative expression factor, we correct the efflux ratio, which reflects the overexpression, by this relative expression factor to obtain our predicted in vivo Kp,uu of these drugs. Now, of course, we can all do all these predictions, but the question is, are these predictions correct? And do they really predict the in vivo Kp,uu observed in maternal fetal dyads? So we took, for these drugs, and this is why we chose these drugs, because these umbilical venous maternal plasma concentration ratios were available in maternal fetal dyads for all these 7 drugs. So we took these and determined the in vivo KPUU of these drugs. And here we have our predicted KPU. So then we ask the question, do they match? Does the in vitro KPUU predict well the observed in vivo KPUU? And the answer is yes. So here is the predicted KPU in blue, and here is the observed KPUU for all these drugs. And you can see that our predictions match the observed values really, really well. And because we have the placental PGP and BCRP expression in earlier gestational age placentas, we can now predict for not only the term pregnancies what the UVNP ratio will be, but also for gestational week 25, for example, and gestational week 15. So we can predict these fetal exposures all the way from 15 weeks of gestation onwards. The reason why we cannot do it earlier than gestation week 15 is because we don't have many of the physiological parameters for the early first trimester pregnancies. We've also asked the question whether we can predict fetal tissue concentrations, because that's what determines fetal toxicity of drugs through our maternal fetal PBPK model. So we have been conducting a THC study in determining fetal exposure to THC, and we were fortunate enough to obtain second trimester fetal tissues like the brain, kidney, and the liver in women who were consuming cannabinoids during their pregnancies. And we also did a study of these women at term who delivered live births and measured the umbilical venous plasma and maternal plasma concentration ratio. And you can see here that our predicted THC concentrations, ratios, through our maternal fetal PBPK modeling predicts very well the observed values. The observed values are the ones in the black circles, filled circles, and the confidence intervals are the confidence intervals of the data that we collected. So our predictions are all within the confidence intervals. And for UVMP ratio, we basically predict the concentration ratio really, really well. In my wildest imagination, I never thought I would get a maternal fetal PBPK model published in Nature journal, but they were interested and we were able to publish this in Nature Communications earlier this year. So just want to summarize here that PBPK modeling and simulation combined with the REF approach can predict maternal fetal exposure and fetal drug concentration, including those that are actively transported by placental transporters. And now that our predictions have been verified, such predictions possible for all stages of pregnancy can be done without conducting in vivo studies, because of course these are logistically difficult to do, provided that the drug transporters transporting the drug across the placenta are known. And these predictions can be used to inform appropriate preclinical animal toxicity studies and optimize dosing regimens for the pregnant person and her fetus. Nevertheless, much research remains to be done on how pregnancy can affect fetal drug exposure, efficacy and safety, and therefore optimize drug therapy for these orphan population. And we are fortunate enough that NICHD has funded 4 transport elucidation centers at the University of Washington, Johns Hopkins University, Rutgers, and UCSF to do research in this area. And I'd like to close by acknowledging contributions by an excellent team of present and former postdocs and graduate students in my laboratory, my collaborators from within and without the universities, and also data generally supplied by various investigators to help us test our predictions of KPUU in vivo. And I want to thank you, the American taxpayers, for voluntarily donating your tax dollars to the federal government, which made a first pass through numerous grants that then came to us, as well as the Bill and Melinda Gates Foundation for supporting this work. Thank you. And I'd be happy to discuss this presentation during the panel discussion. Thank you.